Do you have a change? Okay.
Yeah. So my turn. Right. So what I'll quickly do is, since the topic is about beyond using conventional CPAP and sleep surgery, so try and highlight the progress made in the different fronts of OSA. So if we continue to just work in a hole, in our little corner, just looking at AHI, mild, moderate, or severe, and then do we do nose surgery or palate surgery or tongue-based surgery or multi-level surgery, and that's all we do, then we are bound to fail in some patients, and our patients are not getting the best care. Because there's a lot of work going on in so many other areas. And just in the last 5 years, they've come to at least understand, right? We've come to at least understand that sleep apnea or sleep breathing disorder is a broad spectrum. And besides the upper airway, which we are concerned with, right, which I've put right down there, are other concepts such as loop gain, arousal threshold, and dilator function, which we do need to understand if we are really going to approach the patient in a holistic way. Okay, so I'll highlight these one by one, and what are the implications in terms of treatment and so on. So I've already showed this. All right, so in the structural side, I think the whole of today we've looked at the various ways to approach this, okay, from nasal surgery to oral appliances to expanding the maxilla and MMA, and also tonsils and adenoids and so on. So we know there's a skeletal box, the soft tissue contents, all right? And in terms of reduction in airway or reduction in airflow, it's both obstruction and collapse, or as JJ says, static and dynamic, right? So if it's a static obstruction, then you have to remove that soft tissue or enlarge the box. If it's a collapse, then you want to tighten it, all right, stretch it out or shorten it. So these are all the various philosophies and ways. So if we try to keep it as simple as possible for ourselves, when we look at a new surgery or a new procedure, what is it that we're trying to achieve? And these are basically the structural endpoints. But when it comes to function, this is where we lose ourselves a bit. This is where we are groping in the dark, because we are not so familiar, and we've not taught ourselves these things. We've not been taught these things. What is arousal threshold, loop gain, and dilator tone? So I'll just highlight the research about this. So again, a recap. This is an excellent summary to go back to, the paper from obesity surgery that summarizes the various factors involved, the phenotypes, and really looking at where we are trying to intervene for each patient. So remember, every patient will have a mix of these factors, and our job is to try to work out which is the major contributing factor that we want to tackle first, and maybe that, gives a good chance for the patient to have the problems fixed. Okay, so for ENT and maxillofacial, most of us are going to be working on the left side of the equation, right? The bony factors and the local tissue factors. But what about the dynamic problems? And this is where it gets interesting, and when we look at the physiology, it's very interesting. But also, it actually shows us why, in many patients, we fail in the first place. Surgery fails, CPAP fails, and therefore, what are the new interventions for this? So the first thing about dilator muscle abnormalities, right, is looking at pharyngeal dilators. So one way to get the pharyngeal dilators working is hypoglossal nerve stimulation. And Peter knows a lot about that. He's shown us in past meetings about hypoglossal nerve stimulation. So that's one way to synchronize hypoglossal nerve activity with diaphragmatic activity. So when you try to breathe, right, the genoglossus contracts and therefore opens up the airway. Yeah, very elegant solution, slightly invasive, but very costly, right? So it's difficult for us to bring into Malaysia. Okay, then there's now experimentation on drugs, right, like atomoxetine and oxybutynin, that happens to be able to improve genioglossus muscle responsiveness. So what we want to do is to increase the sensitivity, right, and the arousability and sensitivity of these muscles to the breathing stimuli. What stimulates the genioglossus. What stimulates these pharyngeal dilators? There are actually two things, all right? One is the hypercapnia, all right? And two is the negative pressure in the airway, okay? So when you reach a state where there's negative enough or low enough intrathoracic pressure, right? The effort to breathe against a closed airway, when there is that, or a narrow airway, when there is that negative pressure, there's actually a signal, all right, to the hypoglossal nerve to dilate. Okay, so drugs have been shown to be able to help because basically, if you have something that is, it's basically a serotonin-driven response. And so if you've got drugs that can modify this, right, then we can actually modulate the brainstem response as well as the hypoglossal nerve to be more contractile, be more responsive to these thresholds, to these stimuli, meaning hypercapnia and negative pressure. Okay, we've talked about myofunctional therapy. So that's another way to address dilator function, right? To strengthen the genioglossus as well as the lateral pharyngeal muscles, and of course to ensure lip seal and nasal breathing. Okay, so we've talked about this already. So if you look at these different, this review of different interventions for dilator function, right? You've got on the first half, your hypoglossal nerve implants, right? Inspired to upper airway stimulation, showing decrease in AHI, can be up to 68% in some studies, right? The Stroller study and then the Woodson study is AHI decrease by more than 50%. Okay, using pharmacological treatment, right? The study by Prasad using ondansetron and fluoxetine showing a decrease in AHI of 40% at high dose. So there is hope out there for pharmacological treatments, and we shouldn't ignore these. And they may be actually come in handy when we can work with a physician or respiratory physician to combine our treatments. Okay, so again, atomoxetine and oxybutynin, the one that I showed earlier, right? In a group of up to 20 patients, the median AHI change of 63%. So that's actually remarkable, right? Some of us can't even achieve that with some surgeries that we do, all right? And then in terms of upper airway exercises and myofunctional therapy, the lower half, right? You can see in moderate and moderate to severe OSA patients, you can decrease the AHI in adults up to 50%, right? Okay, so that's for dilator function. Now, then there's this whole other area about respiratory control. Now, this becomes a bit complicated, but I'll just try to highlight in the best way I can what these two things are. What is high loop gain and what is low arousal threshold. So high loop gain works like this. If we are constantly exposed to conditions of hypoxia and hypercapnia, then the chemoreceptors, right, your carotid chemoreceptors, become hypersensitized. Okay? When they're oversensitive, then when they do kick in, they kick in with a hyperventilatory response, meaning you overventilate, you hyperventilate. All right? So because of the obstruction, initially, right, you go into very severe hypercapnia, right, CO2 retention, and even hypoxia. So these chemoreceptors, having been exposed to these conditions, now have tried to catch up. And when they try to catch up, they now have they're hyperexcitable. So when you're hyperexcitable, what follows is then hyperventilation. When you have hyperventilation, you wash out all the carbon dioxide. And then they lose the respiratory drive. So it's a vicious cycle. You lose the respiratory drive, what follows is then a central apnea, right? And so this goes up and down. So you have a very unstable ventilatory pattern, all right? On one hand, you're hypoventilating with the obstructive event, and then next thing you're hyperventilating, and then because of the hyperventilation, you lose the respiratory drive, and then you're hypoventilating again. So it's a vicious cycle. So there's a way to calculate this loop gain. There's a way to actually diagnose these loop gains. What works with loop gain is to give them oxygen therapy, carbonic anhydrase inhibitors, right? All these are experimental and in research to show that they actually do work to reduce this high loop gain, right? Zonisamide, stabilization of CO2, and even combination of oxygen therapy and hypnotics. Now this is strange, right? Why would you give a hypnotic to someone or sedative to someone who has already got obstructive sleep apnea? Okay, so the next thing would be this, right? The low arousal threshold. Okay, so the last one. In low arousal threshold, what happens is that the hypoglossal nerve and genioglossus is unresponsive. Okay, so the patient has to go into, in an obstructive event, has to go into very deep negative pressures before the genioglossus and other dilators are stimulated. So again, when this happens, when there is a stimulation, again, it's the same, almost the same vicious cycle that you get in high loop gain, right? There's a overdrive, okay? Initially, there's an overdrive into a hyperventilative response, driving down the CO2, and then resulting in a central apnea. And this is why we see patients with mixed apnea. If you look into your sleep studies, you'll see some patients have an obstructive event followed immediately by a central event. We call those mixed apneas. And that's why. Now we understand why there are mixed apneas in the first place. And now we understand why, when we give even the mild and moderates CPAP, even their central apnea comes down. We used to know this. We know that when we treat mixed apneas, the central apnea figures actually come down eventually. But now we know why. We know that what we're doing is to prevent this hyperventilatory response. So they've in fact looked at trying to increase the arousal threshold, make you less, right? Increase the arousal threshold, right? And therefore, you doing that actually reducing the AHI significantly. Okay, so I think these are some of the new things to look at, and there's actually a way to score it because we don't have access to using an epiglottic esophageal catheter and measuring the epiglottic pressure to know how low the threshold is, right? How low the pressure has to go before the genioglossus is activated, right? Which you can see on the graph there. So they found a way to very conveniently score it, right? If the AHI is more than 30, is 1 point. Your lowest saturation is constantly above 82.5%, but your frequency of hypopneas is high. So that means you don't need a very low oxygen level to get these hypopneas. You get it? Right? They have high AHIs, but the hypopnea is also very high rather than apneas, but the oxygen doesn't have to go very low for this to happen. So basically it's a logistic regression model to calculate this. So if you've got 2 or more, it shows that the patient has a low arousal threshold. Right, has 84% accuracy. And so with these, the way to treat them is actually to give them drugs to increase their arousal threshold so that they're not as sensitive. And that actually brings them back to a more stable ventilation pattern. Okay? So 1/3 of patients actually have this low respiratory arousal threshold, and so many strategies looking at using hypnotics. So very counterintuitive, using hypnotics to treat OSA, but in fact, in one subset of patients, this may be exactly what they need. Thanks.
Dr. Walker, do you have any last words of wisdom? Because we are out of time.
Well, let's get out of here. Yeah.
He left you 20 seconds, your friend there.
All right, well, let's pop up here we go. Well, one thing I want to say, just hearing this, and what I've just heard from you two fine gentlemen is we're all concerned here and looking at, where's that flicker? You got a clicker? Yeah, there you go, thank you. You guys we're still dealing with end stage, mechanical things to correct somebody who's got the darn disease. Now, I'm gonna put a plug in here. We got 2 lovely dentists down here and an orthodontist over there. It's gotta come back into prevention. It's gotta be recognized early so we're not dealing with end stage mechanical devices to keep people limping along, putting in $70,000 implants for the nerve.
I think we said that in the very beginning. It might have been the 3rd slide.
What's that?
I said that was the first thing I said.
Yeah, well, that's it. It's got to be prevention. So here we go. You got to bridge the gap. We got to talk together. We got to get together and do these things. Change the current thinking, dental and medical professions. And in schools, we got to teach, recognize this stuff. And that's what we have to do, what we're doing here. And I thank you guys, JJ and Cool Jet, for putting this all together. But basically, it's here. And I see right now, you got to use that CBCT. You got to have a cheap, low radiation way of recognizing it and see it quick and fast, rather than you guys put 1,000 microreceivers in the hospital. So this has got to be out in the general practitioner's office to see what's going on. So that's very important. Know the airway anatomy. We've got to learn the anatomy. Our dentists really have to know what we're doing there because we can see it sooner. Pharyngeal airway volume. We know what that is. We've got the measurements. We know what's functional, what's not. We need to be aware of these things. So we need education. This is what we need to do to keep this going. So CBCT stuff, extremely important. Nasal surgery clears that up. Now this is, again, this goes back to Peter's stuff. This is fascinating. Before nasal surgery, he had it was 756, 7 cubic centimeters, 56. Went to 1918. Just simple nasal surgery did this, guys. Look at this, increase airway by clearing the nose. You've got to get aggressive. You got to see what you're doing there. So I implore you to do that. This is just a collage of those, what do we have, 30 patients. These are the adults. This is the airway increase in every one of those. But again, that is just, we're dealing with end-stage people. Of course, we got to take care of them, but we got to prevent it. Never let it get to this point. Let's put these CPAPs out of business by not ignoring it while we're growing. Here, recognize this stuff, take action and do it. Look in there. So it's education, root cause of disease. Find out what the root cause of our disease. We need our medical community not to keep throwing pharmaceuticals at them and chasing tails just to monitor and do things with pharmaceuticals. Go back to the origin. And we know right now, we think we know where the origin is with so many of these things. And it's in the nose and breathing. Another thing too, I don't know how we're going to stop this. The sugar and crap right there, man, those are the big drugs that are killing us. You got to shop on the outside aisles of that grocery store. You don't buy anything in a can. All that crap is coming out in a box in a can. There we go. I think that's it. Oh, well, there we go. There we go. Here's what we're going to change. Mouth breathing over to nasal breathing. That's performance. So start early. Let's fix it. Let's fix our society. Do airway screenings. And start to think about also, bedwetting. How many physicians and pediatricians don't know a damn thing about bedwetting? They never think about breathing. Hearing loss. They start talking to pediatricians and physicians about hearing loss. They don't think about the airway being a problem. This is new stuff. Here's the kind of new appliances that we're using now. But again, these are the Band-Aids that we use. Night guards. Night guards are killing us. You can't use a night guard. It's going to make sleep apnea, takes it from mild to severe.